Good afternoon, everybody. Thanks for the invitation. Pleasure to be here and to talk about IV Glyburide in acute stroke to prevent cerebral edema. These are my disclosures. Cerebral edema in acute stroke is a common problem. 70,000 patients in the US alone have malignant infarction each year. And as many of you know, or all of you know, it is a fatal, often fatal disorder with 60 to 80% fatality rates. And the only treatment we currently have for it is decompressive craniotomy, obviously a quite invasive procedure. And there aren't any good medical approaches, no good medicines to prevent edema. This is an example of a typical patient who underwent decompressive craniectomy on day 1. There's some hypodensity. Day 2 to 3, you see some midline shift and effacement of the ventricles, and then the midline shift is resolves with the hemicraniectomy. So that treatment was shown in multiple trials that were pooled. A small number of patients in these 3 trials together, 93, to be quite effective at avoiding a very severe disability. MRS-4 dichotomization was 75 versus 24% in favor of hemicraniectomy. But there was also benefit if you dichotomized the Rankin at the MRS-3, and there was a survival benefit as well. So these are outcomes at 1 year. So a very effective treatment. But can we do more with medications, and can we avoid these hemicraniectomies? Well, in order to figure that out, we need to first know what the cause is of cerebral edema. And this seems to be a key player. It is the TRPM4 channel that was discovered in early 2000. And it's a very interesting channel that lives in multiple cells within the brain. So this channel is regulated by SUR1 that is associated with the channel. And after ischemia, when there's ATP depletion, there's upregulation of this channel. So the channel usually doesn't really exist in the cells, but is upregulated soon after ischemia. And the channel is activated by ATP depletion. It allows sodium to flow into the cell, and that leads to cerebral edema. And as I mentioned, it's present in many cells in the brain: neurons, astrocytes, endothelium, and oligodendrocytes. So this is from a 2006 paper from Simmert in Nature Medicine, really nice paper that shows in all of these cells, neurons, astrocytes, capillary endothelium, and oligodendrocytes, here shown in red is staining for that molecule that is associated with the channel SUR1, that it's present in all of those cells. In green, the specific cells are labeled, and then on the far right, you see the co-labeling of the cell, for example, the neuron in the top row, as well as the red labeling for SUR1 in an MCA stroke model. So they demonstrated, one, that SUR1 was present, that it was upregulated after MCA strokes, and they later also showed the same in a patient who underwent hemicraniectomy. Tissue was taken from the brain, and the SUR1, the TRPM4 channel, was present also in human tissue. This is what it looks like under electron microscopy. Control cell on the very left, A, and then after ATP depletion, the cell starts to swell up. After 5 minutes, 25 minutes later, there's even more swelling. So you get these large edematous cells that are the cause of eventually the malignant cerebral edema. So what if we block that channel? Well, it turns out that there is a molecule or a medication, Glyburide, that can block the TRPM channel quite effectively. And so they went out in that same paper that was published in 2006 to try to block the channel and see what the effect was on infarct volume as well as on survival. And so this was in an animal study. Infarct volume was reduced by about 50% in the animals treated with Glyburide versus the control patient. So an enormous treatment effect there on the radiological outcome. And as animal researchers always do, they show a nice example of the histology. And so here on the left, the control rat with a large infarct, or mouse, sorry, I don't know what it was. And on the right, minimal swelling. So this also led to great survival advantage among the animals treated with Glyburide, where the mortality was 24% versus animals treated with saline, 65% mortality. 29 rats per group, so this was a rat study. So those encouraging results in animal studies led to the GAMES RP trial, and that was a randomized controlled trial, multi-center, that was published in 2016. So the design was, the patients were included, 18 to 80 years old. They needed to have a large anterior circulation stroke, and that was defined as a diffusion lesion between 82 and 300 cc's. They needed to be randomized within 10 hours after stroke onset. IV TPA was permitted up to 4.5 hours. Thrombectomy was not permitted in this trial. Randomization was 1-to-1. 18 centers were included, and 83 patients were enrolled in the trial. The trial was supposed to enroll more patients, but was stopped early for financial reasons. These are the baseline characteristics, which were well matched between the patients, the 41 in the Glyburide arm and the 36 in the placebo arm, and this is the per protocol sample. Notably, the baseline diffusion lesions were matched, 157 versus 163, and quite large. The minimum, again, was 82 cc's. These were almost double, so these were fairly substantial strokes in the study. The primary efficacy outcome was an interesting endpoint. It was the composite of an MRS 0 to 4 and avoidance of hemicraniectomy. And the primary endpoint was not significant, 42% in the Glyburide arm versus 39% in the placebo arm, and p-value of 0.8. The primary safety outcome was there any serious adverse event, and that was equal also in both arms, 68% versus 72%, p-value of 0.7. And so they looked further in if there was any efficacy on their secondary or tertiary endpoints. So I'll show some of those, and I think that those are encouraging, even though the primary endpoint of the study was not. So here's the 90-day MRS. Oddly, for an acute stroke trial, that was not chosen as one of their, even their secondary endpoint. But if you look at the benefit on MRS 0 to 4, you see a difference in the control arm, 47% achieved MRS 0 to 4 versus 61% in the Glyburide arm. Not statistically significant, but a good trend in favor of the Glyburide. Odds ratio was 1.7 for this dichotomization and a p-value of 0.2. If you do a shift analysis over the entire spectrum of the MRS distribution, it's also in favor of Glyburide, as you can see on this slide, with a p-value of 0.1. And so the difference is that there were some sites that did hemicraniectomy prophylactically, basically, in the study. And that high percentage of prophylactic hemicraniectomy hurt them in their primary endpoint. So rather than waiting until patients decompensated and truly needed hemicraniectomy, it was offered prophylactically in about half of the centers that were participating. Some other endpoints here: mortality, p-value of 0.06 in favor of the intravenous Glyburide treated arm. Midline shift at 72 to 96 hours, 4.6 millimeters in the Glyburide arm versus 8.5 millimeters in the placebo arm, and that was highly statistically significant, so on their imaging endpoint. And here the safety endpoint, they were particularly interested in severe hypoglycemia, defined as blood glucose less than 55, occurred in 9% of the patients in the Glyburide arm versus no patients in the placebo arm. So that was increased, p-value of 0.1. And you see here in the graph, the shaded area in blue at the bottom indicates time points, individual time points, when patients dip below that 55 milligram per deciliter threshold. So those encouraging secondary and tertiary endpoints in terms of their imaging endpoint, the Rankin shift, and the safety led the investigators to actually the drug that was with a small company was bought by Biogen, and Biogen decided then to that these data were encouraging enough to start a larger phase 3 trial that's called CHARM. It's supposed to enroll 680 patients. It has started. It's now enrolled 116 patients per November 1st. And it had very similar inclusion criteria as the phase 2 trial. Lesion volumes now 80 to 300 milliliters. That can be, patient can be enrolled either based on diffusion-weighted imaging or CTP core. They can also be enrolled based on a low aspect score. Age range is 18 to 85. Time, again, less than 10 hours after stroke onset. And this time thrombectomy is permitted. But patients need to get an imaging study after thrombectomy to confirm their final lesion volume for inclusion. Thank you very much.